Hello and welcome, everyone. It's your friendly masked face, Max Orr, Executive Director of Carolina Public Humanities. It is my distinct pleasure to invite you to this virtual Humanities in Action talk. One thing that is not virtual is that we are in a real room. We're in the lovely Flyleaf Books where we do this all the time. I'll mention a little bit of what Flyleaf has to offer you, members of our community, if you're local. If you're not local, come on down to Chapel Hill. As soon as Flyleaf Books opens up its doors again, you'll see it for yourself. I want to welcome everybody to all of Carolina Public Humanities online offerings. We have please go to humanities.unc.edu and take a look at what we're doing this semester. We've transitioned many of our programs that you've come to love, including our weekend seminars and these lectures. We've transitioned them to an online format. We're playing with new technologies and trying to do our best, so please also let us know what you think and how we can improve. But we do hope you join us and come for some of our wonderful programs. I'll mention a few of them in just a moment. Before we get too far, I need to thank many people who make this possible, including our wonderful partners at the General Alumni Association, who have really partnered with us, especially as we transition to online programs, and are going to be wonderful partners for these Humanities in Action talks and, of course, our Ventures and Ideas weekend seminars. We also are planning another version of our biography series, which we'll be announcing soon with the General Alumni Association. So thank you to everyone there at the GAA for all their help. And if you're not a member, please sign up, sign up, and get involved. We also want to thank the Cotton Merca Group at Morgan Stanley, a longtime contributor to our programs, especially our K-12 programs, and Carolina Meadows, a retirement community in Chapel Hill, which has been a longtime supporter of our public programming and also has just joined up to support our Carolina K-12 Teacher Workshop program. So thank you to all of our sponsors. And a special thank you to our partner in this project, Flyleaf Books. We've been working with a true sign of civilization is a independent bookstore, fully functioning. And Flyleaf Books is fully functioning, folks. They're doing brisk book sales, so you can order and pick up in front if you'd like. They have special book sales right now on cookbooks and children's books, and, of course, a roster of events, including on September 10th. Our good friend Gene Nickel will be giving a talk for Flyleaf Books. So go to flyleafbooks.com to get a sense of the various programs that they have and some of the sales and incentives that they have. I also want to just remind you folks to go to humanities.unc.edu to take a look at all of our programs that we do have available. Registration is open for Humanities in Action, these talks, as well as for Adventures in Ideas. And finally, folks, I want to just remind you that we are still working very hard here at Carolina Public Humanities to do our service, and that is to be a bridge between the scholarship and faculty at UNC and the broader community. And of course, we're doing that right now as best we can in this virtual world, but we continue to do our incredibly important work with community colleges and our state outreach, partnering with them for online projects, as well as our teacher workshops, which we have now, of course, fully migrated online as well. Carolina K-12 and our community college outreach are going strong, but we need your help. So if you would like to consider giving to Carolina Public Humanities to help us continue this important work, spreading humanities research, asking important questions in the community, and reaching those communities like our community colleges and teachers. So thank you for considering that. Now let's get to the important part, and that is to get to our talk. We are delighted that Jim Thomas, Associate Professor of Epidemiology and the Director of the Measure Evaluation Program at the Gillings School of Public Health, is with us today. Jim, we're dropping the bio in the chat section so you can get a longer look. We don't like to read CVs, but I do want to tell a little narrative of how this developed. Jim was actually scheduled to give a talk with us in April that was going to be on medical ethics, looking at issues of privacy and some of the new technologies that are coming on board that have real ethical implications for living in modern society. And it's certainly a great topic, and one we're definitely going to bring Dr. Thomas back for. But in the intervening time, we've had another public health issue. I'm not sure you're aware of it, but Dr. Thomas will speak about it today. It was called COVID-19. And luckily, this is not Dr. Thomas's first pandemic, and he's already thought carefully and thoroughly about the ethics of pandemics, including a resource, the Pandemics Dashboard that he's created, which he'll speak some about today. So an incredibly important issue, one that I'm glad that we can bring this program to you and the public, and we're really looking forward to learning more about the ethics of pandemics. So without further ado, please welcome Dr. Jim Thomas. Jim, come on in.
Thank you, Max. So we are separated here, and I'm going to take my mask off so you can hear me, and I am a safe distance from anybody else in the room. So Max introduced me as an epidemiologist, and you may wonder, what is an epidemiologist doing here to talk about ethics in a humanities program? I began my work in epidemiology in, my academic work in epidemiology in central North Carolina. I guess we should call it more eastern North Carolina, over by the I-95 corridor. I was doing work there on studying an epidemic of that time in that community. And there were a lot of race issues that were coming to the fore. And they were quite striking. And I wanted to be able to talk about them, and with a language that my colleagues would understand and would respect. I went to familiarize myself with medical ethics, and the shelves in the library were those that were about health ethics were all about medical ethics, which comes from a very narrow, a very particular imbalance of power, which is between the physician and the patient. And that was not the power imbalance that I was dealing with. I was in an imbalance between the government and a whole population. And race issues in those who were working in the government, and how the population that was affected by this epidemic, how they were being affected by those race issues. So I took a sabbatical, and I studied ethics and philosophy for a year, and came back into my public health work at UNC. I began making noises at the conferences I was going to, and asked, is anybody else thinking about some standards for ethics in public health to distinguish them from medical ethics? Found a group. They were well connected. We wrote a code of ethics in public health, and with that code, my name gained some prominence in those circles. I was asked to be an ethics advisor to the director of CDC for a number of years. And it was at that time that the world began preparing for the H5N1 influenza epidemic. And we wrote a lot of recommendations and guidelines for how to deal with the predictable ethical issues of that pandemic. I'm going to be drawing upon that knowledge as I speak to you, but also, of course, the knowledge of my direct experience. And then I'm going to mention just one more pandemic that I have dealt with, and that is the HIV pandemic, which was early in my career. This was in the 1980s. And there are some parallels there as well. So you might say this is not my first rodeo. I have been through pandemics before. As I speak, normally as I speak, I would be walking around and talking in a fairly casual way. Because of this setup, I'm pinned here. But I don't want to be pinned intellectually. I want you to be interacting with me as I speak. I welcome interruptions. So as I'm going through my slides and making points, if there's something that strikes you, just send off in the chat function or whatever, send off a question. Max is watching those. He's got his own microphone back here, and I've asked him to please interrupt, and yeah, it'll maybe relax this interaction that we're having here just a little bit. So let's move along. So where do we stand now with the COVID pandemic? This is a graph that I clipped off the web fairly recently that is showing the U.S. cases and the trends that we have gone through. You can see that we're currently in a decline in the number of cases, but it's a decline to a place that is still quite high. 5.8 million cases. I think I heard on the news today that we've just passed maybe 6 million, and over 180,000 deaths. In North Carolina, our curve is a little bit different. We've had a steady rise. While the U.S. went through a bit of a plateau, North Carolina just kept rising. And we've had a bit of a decline more recently, but also if you look carefully, you see it shooting back up there at the very end. I don't know if that's because of students coming back to campuses. I couldn't tell you exactly what that incline is about. So that's where we are in the pandemic. What about where we stand in comparison to other countries? Well, this is the case rates that you can see over time. I call them a rate because they're divided by the population, so it's a what we would call a fair comparison between countries or regions. The top line here, the one that has risen the sharpest and the highest, is the U.S. And the next line down, which should be read to you, I am hoping, is Latin America. The third one down, green, is Europe. And then gray for other. And the very bottom one down there is China, bumping along the bottom. If we look now at the death rate, it's slightly different, but the rank order of those regions remains the same. The U.S. has the highest rate, then Latin America, then Europe, and then at the bottom, China. What makes this ethical? Why are these rates an ethical situation? Isn't it just entirely a biological issue or an epidemiologic issue? Well, it's ethical because power is involved, and where there is power, there is ethics, because there is the opportunity to abuse power. So we write ethics to say that this is how one is to manage that power. Sometimes it's at a very individual small level. I have the power, you just saw me have the power to take off my mask. I have the power to put my mask on. It's a small bit of power, but I have that ability. Then there's power at very high levels, of course, at national levels in putting in place restrictions or creating laws or paying for covering the salaries that have been lost. So there's a whole range of different kinds of power, and ethics speaks to what we consider to be right and ways to behave in those questions of power. Within that range of questions, there is also a consensus of right actions. Ethics speaks of a consensus that people have considered what those power issues are, and this is how we are to behave. And then the figure next to this point is the Public Health Code of Ethics, which just before the pandemic was revised in its second edition and became much more useful. I think I may have mentioned that I was involved in the writing of the first code. I was the principal author of that one. And in this one, I just played the wise overseer and helped people to revise the code. But it's been very helpful as we walk through this pandemic. And then the last thing I would mention is a difference between institutional actions and personal actions. I'm going to be talking about institutional actions, the institutions in our lives that have power over what we are allowed to do and what we are not allowed to do. There is much that can be said about individual actions and individual ethics, but when we're in the realm of public health ethics, at least the way that I'm addressing it, we're in that place where we are talking about a public health department or a whole state government or the national government that is making decisions about how a population is to behave. Now, here is a point that I already mentioned in my introduction, where I was talking about in medical ethics that it's different than public health ethics. So let me dig in just a tiny bit deeper in talking about that. In medical ethics, one of the principles that rises quite high, you consistently see it in discussions about medical ethics. It's the idea of autonomy. And the autonomy is where the patient has the right to disagree with the physician, has the right to say, no, I'm not going to take that recommendation. I'm not going to participate in that study. Because of the power imbalance of somebody who can hold a scalpel and somebody who would be under a scalpel, we preserve some ability to give some power to the patient. Now, in public health, however, it's a different arrangement. It's a whole government that is interacting with a whole population. So the power imbalances and the power questions are different. Also, if I, with my mask off, were now to approach Max, who is behind the camera, and if I were infected, I don't think I am, but one has to, you can't assume anything anymore. I conceivably could infect him, and so my infection is his exposure. And I have to give up some of my autonomy, my ability to do what I want, because I care about him and his health. I have a duty to him. So in public health, we have this trade-off of we don't want to give up all autonomy, but we don't make that the sole factor either. So in public health, the thing that we accentuate is interdependence. That my health depends on you, your health depends on me, particularly when we are in the same room. And this diagram here shows that with a sneeze, that the sneezer can affect the sneezee, the person who is going to be receiving any kind of an aerosol that comes from that sneeze. So the interdependence changes how we behave and how we design ethics in public health, especially in a pandemic where we are acutely aware of how each person affects the others. I mentioned that for a while I was an advisor to the director of CDC in ethics, and during that time we were dealing with pandemic flu. These are two covers of documents that were written during that time. The one in blue comes out of the World Health Organization about ethical considerations in a pandemic. The one on the right, it was a little boring, so I cropped it to just the title. It was just white and hard to read, but that came out of the Centers for Disease Control, and it's ethical guidelines for pandemic influenza. These two documents, a couple of others, and the Public Health Code of Ethics have been brought together into a dashboard that I have developed that enables policymakers, lawmakers, people working in public health departments, other people in places of power. It gives them the right or the ability to quickly find ethical questions and guidance for those questions.
And speaking of questions, do you want to take one question?
I'm eager to take a question.
Okay, to be clear, I hope everyone can hear me as I deliver this question. This is from our good friend Bill Harrington. What code of ethics impacted on public health before you developed the first code of ethics for all public health? Did each discipline within public health have its own code of ethics?
There are different codes of ethics within public health. Health behavior has a code of ethics. Epidemiology has one. And one of the tasks that we had as we were putting together our code is to check against those and make sure that we weren't in any kind of gross violation or disagreement with them. Each of them had a much narrower scope. They were fairly technical. Epidemiology was very closely aligned with research ethics. But if we go back further, what kinds of ethics codes were available to public health? It was largely governed by medical ethics, and that still happens. I will go to meetings where we were talking about public health. And because so many people have been trained in medical ethics, that is what they will refer to, and they will start pulling up these 4 basic principles of medical ethics, autonomy being one of them, and begin framing things in that light. So it was because of that misfit between medical ethics and what I was running into in public health that gave me the discomfort that led to the creation of this new public health code of ethics. Thank you for that question. So now let's start looking at some of the issues within public health ethics. And the one that is going to rise to the top is trust. Trust, because in public health we don't have, well, public health does have what are called police powers, but it uses them very sparingly. An example of a police power would be shutting down a restaurant where there has been a foodborne infection. In my early career, I was an epidemiologist for the Los Angeles County Health Department. I did outbreak investigations in LA for the better part of 3 years. And we did close some restaurants. That would happen when, in one instance, one of the cooks had hepatitis. And that can be communicated or can be transmitted through the food. So we needed to close that shop. He needed to get treatment. The restaurant needed to check its procedures, needed to clean everything, and then eventually it was reopened. But that's an example of a police power. But public health uses those powers very sparingly, and it doesn't have a big stick to make things happen, particularly in a democracy. In some countries, you have bigger sticks. In our country, we don't use that stick very often. So we use a carrot. And the carrot that we have is trust. If a government is asking a population to go into physical isolation, well, there needs to be trust that that is necessary and that the things that we need will somehow become available, that there won't be undue suffering. There will be suffering, but there won't be undue suffering. If there is strong trust in the government, then that arrangement can work. So this Public Health Code of Ethics, in talking about trust, says the effectiveness of public health policies, practices, and actions depends upon public trust gained through decisions based on the highest ethical, scientific, and professional standards. Where there is trust, any number of things can work among those who have that mutual trust. Where there is no trust, or where trust is thin, hardly anything can work. Most anything can be undermined. We are all hoping for a vaccine. If that vaccine is not trusted, then not enough people will get vaccinated, and we won't achieve herd immunity, and transmission will continue. So the trust that public health operates on is, I would say, the highest of the ethical principles. But now I'm going to take you in a different direction, into biology, because there is much about what we are dealing with in COVID that is based in the biology. One of the powers that public health has is its scientific knowledge of how the organism is transmitted and how to stop it. So one of the goals of public health is to be effective. And if it knows something that would help and it doesn't implement it and people get sick, that's unethical. So it's important to understand the biology of the organism. It's not the only thing we need to understand, but it is a very important thing. So many of us have been hearing quite a bit about this reproductive number, symbolized here as an R sub 0. And there's this equation. It's a shorty. It's not going to be too burdensome. But the things that determine this R sub 0 are called beta, C, and D. Let me first tell you what the reproductive number is. If I am infected, it is on an individual basis. R is on a population basis, but on an individual basis, it would be the number of other people I have infected. If I'm detected as infected and I go into isolation, I don't infect anybody else, well then that R would be a 0. And if on a population level everybody did that, we could get the R pretty darn close to 0. But if when people are infected, they continue to go out and about, not wear masks, get into close associations and connect with each other, then you're going to have an R that goes above 1. If it's at 1, then one case replaces another case, and the level of the epidemic stays plateaued. But if the R is greater than 1, it begins to rise. So what are the factors that feed into this? They are the infectiousness of the organism. Is it highly infectious, or is it hard to pass on? The contact rate. If you just hold the infectiousness still, but you interact with a lot of different people or nobody, that's going to make a big difference in the transmission in this population. And then the third piece of this is the duration of the activity, because if you have a long duration and you have a certain contact rate that you just persist in, then you have more and more opportunities to pass this on. So when it comes to COVID, and we're looking at infectiousness, we begin to think about masks that would decrease my risk of passing on the infection to somebody else. I become less infectious. One of the things I thought about when I came into this room was the air circulation, because we now know that that makes a difference. We know that the virus can linger in the air, but it does so less when there is good air circulation. Our technical guy, as I said, that just looked up at the fan, so I see my point was made. When we're thinking about the contact rate, we're talking about physical distancing and staying away from others so that we lessen that contact rate. When we're thinking about the duration and the infectivity, we would think initially about antivirals. These are medications that we could take once we get infected that would shorten the duration of the infection. All right, so there's your basic biology. Now we're headed into going back over that with something a little bit more graphic, which is tiny for me, so it's going to be hard to read these particular organisms. But from a distance, I'm going to tell you some things to look for. So what we're looking at is, let's see, infectiousness is on one side, and is it case fatality on the vertical? Percentage who dies, case fatality. So as you go higher in this graph, it's more dangerous. As you go to the right, it's more infectious. And then if you look in the orange box, it says this is what we know from science about both the case fatality and the infectiousness of this organism, of COVID-19. So I think if we go to the very top, well, close to the very top, this one I can read. I can see Ebola. That's way up there high as something that has a very high case fatality. And then if you go down lower and far to the right, you're going to see measles as something that is highly infectious. All right, so when something is highly infectious, as we would consider COVID, I know it's left of measles, but it's still, compared to some other organisms that we deal with, considered a fairly infectious organism. When it's infectious, we have to have quick action because we need to stop that transmission, that contact rate or that duration. Otherwise, if left unchecked, it's going to be passed on and just build up a large number of cases pretty quick. We need to, public health ethics would say, use the least restrictive measures to achieve that goal. So we don't want to use a ridiculous example. We don't want to put everybody in a cell so that they can't interact. We can send people home where they can be in the places that they are comfortable and they have things that they need. And then because of what we know about behavior, we need to have some enforcement of these things so that people do stay where they need to be, that people do not interact as they might. Here is how important quick action is. We are looking at the story of two cities in this chart here, New York and San Francisco. There is, on March 16th, the Bay Area put in place shelter in place, which is what we called everybody go home and stay there. New York did not. Now notice on March 16th that the rates of disease, the rates of infection in San Francisco and New York were very similar. New York was just maybe a little bit above, but not a lot above. But now we move just 6 days down the road when New York has not put in place shelter in place, and look how that curve rises. It wasn't until March 22nd that New York put in place its stay-at-home order. This is something that is very graphically occurring in New York, but it also occurred in our country because we were relatively slow in action and the epidemic got very well established quite quickly. What about the ethics of asymptomatic spread? These blue horizontal bars represent the time in the life of a virus, of an organism, they aren't all viruses, when it can be transmitted before symptoms. The bar for COVID is a relatively long bar. There is a bar within the bar of COVID. There is a dark orange within the lighter orange. The dark orange is more of an average, a usual, a typical duration, and the longer bar is a possible transmission that can occur. But the bar for COVID is quite long. And this is the bane of epidemic control because we don't know who is infected and we don't know when we ourselves are infected. In fact, so symptoms haven't occurred yet. We're unsuspicious, but we may continue interacting with others and transmitting. So when this is occurring, there is a weak link between the actions and the consequences. You have a party and you don't get sick the next morning as you would with food poisoning, so you don't have this link of cause and effect. It's 2 weeks later. And 2 weeks later, when you get sick, you might be thinking, well, was it this or was it that? I wonder what it was. Was it when I went to the grocery store? Or maybe it wasn't the party at all. But the link between the actions and the consequences become very weak. And for that reason, we need to do a lot of research to figure out what are the links, what are the things we need to look for. And we need to, however, act before the research because research can be very deliberate and very slow. Because we are acting before we have all of the research, we are going to need to make some path corrections. We are going to make some mistakes as we figure things out, as we have done with COVID. We have said at one point that don't wear masks. We need to reserve those for the medical people. And that was a valid point. But then down the road, we said, no, wear masks because that helps against transmission. So what was perceived was a mixed message and confusion. So another major point of public health ethics is humility, that we need to be able to admit when we have made mistakes, figure out the better or the right answer, and then move on. And in doing that, we need to be transparent, which is awfully difficult for people in high positions. But if we're ever going to need to restore trust, we need that transparency. There is an ethics of communication in this quick action. So in the ethical considerations in response to pandemic influenza from WHO, there is this statement. The principles of outbreak communication are trust, transparency, communicating to the public early, dialogue with the public, and planning. So let's take a look at the communication that we have had at our federal level around COVID. So the line, this yellow line that looks like a slash across my slide, looks like a mistake. It's not. That's my attempt to be artistic and show that during this whole conversation that you're looking at here, the cases were rising steeply. In December 31st, we have our first reported outbreak in Wuhan, China. And then about a month later, the president was informed of a potential pandemic in our country. On February 26th, he says it's going to disappear. So his statements are in yellow and on the right, and on the left is the patterns of what was happening in the epidemic. And then March 16th, the administration, his administration, so him as well, recommends social distancing. March 24th, however, there is a statement that where the light is at the end of the tunnel, things are looking good, but just 2 days later, the U.S. is the country with the most cases of any country in the world. On April 3rd, the CDC recommends masks. I mentioned that just a minute ago. They came around and said, nope, we take it back, we recommend masks. And our president said, you don't have to do it. I am choosing not to do it. And then on April 17th, when we had protests against restrictions, there was some cheering of the protesters in a tweet that said, "Liberate Michigan." So this overall picture is, I put this up here to, I'm trying not to demonize, but what the end story here, the end result here is confusion. And if we go back, can I go back? Yes. So if we go back to this trust, transparency, communicating early, dialogue with the public, and planning, the communication was not early, and it undermines trust because there's what is being said by the person in power is not matching what people are experiencing. There is another ethics of being essential. This is one of the things that has come about in this pandemic that is different than what I experienced when we were preparing for H5N1, for influenza. When we were preparing for that pandemic, we were talking about essential personnel. And the essential personnel at that time were people who were in places of power. They were governors and mayors and the police. And those people are essential. I'm not saying they are not. But there was no mention of meat packers. So when we come around to COVID, we find that people who are holding our society together at a grassroots level, we suddenly recognize their essential nature in our society. And we see here on the left that because of the coronavirus, that Trump orders meatpacking plants to stay open. They were declared essential. Well, once declared essential, they now have to show up to work. So as they show up to work, you see this picture on the right. This is a chicken processing plant. These places are chilled, which the virus loves. It just keeps it right temperature for a virus to stay preserved. These, you see people that are standing very close to each other, and transmission is going to be possible. There are also people on both sides of this conveyor belt. The conveyor belts move very quickly, and so people are energetically working and expiring air. All of this sums up to an ideal place for transmission. And we have now said that it's essential that these people go into those places. So ethical issues arise. This is one of them that we did not anticipate, but has come in full force with COVID. There was a study of meatpacking plants in North Carolina, and DHHS is the North Carolina Department of Health and Human Services. They have been reticent to talk much about the meatpacking plants because these are privately run businesses, and they argue that public health doesn't have a lot of power over privately run businesses. So there was a news organization that said, okay, well, we will do some research and find out what's going on with the meatpacking plants in North Carolina. So here is a map of a good number of them through within counties of North Carolina. I believe there are many more than this. I've heard, I think that there are 200. And now if we home in on just one of these, you can see the meatpacking plant in that one county off on the right, and then there are cases in the surrounding counties, and these are of people who work in the meat processing plant and then go home to that county. Now, we don't know whether the infections, which direction they are traveling. whether they are traveling from home to the plant or from the plant to home. It can go both ways. But what we do see is a catalyst of this meat packing plant. Another question?
Well, since we're talking about all of these plants being in North Carolina, and you did just speak to the federal response, we do have a question. Let me get
good.
Who asked the question, because I like to give credit where credit is due. We have a question from Peter Billingsley. Can you offer a critique of Cooper's response, I guess, on the state level, and perhaps even speak to the differences of moral authority between federal and state?
Well, so I wonder if that is a broad question about how Cooper has managed the pandemic, or is it about this specific item here?
It seemed like a broader question.
Okay.
In before this slide.
Okay. Oh boy. I have been able to peek behind the curtain in what's happening within DHHS. I've been in committees that are making decisions, and I have a spouse who is a physician who is involved in other things related to farm workers. And we have seen the state take some good actions. They have been much more willing to admit where the problems are. They have they stood their ground when it came to the Republican National Convention in Charlotte. So I credit them with standing their ground there. I have been less than pleased with the sharing of information about this particular topic around meatpacking plants and farm workers. There is more data that I would like to see shared. There are more actions that I would like to see taking place. There is an executive order that came out just today or yesterday that relates to this. I haven't read it yet, so I'm not going to try to speak about it, but I know that it is addressing farm workers, at least in part. So there are being actions taken. There is a distinction between how our state is handling things and how the federal government is handling things. Some of the issues that essential workers face, they have a greater, because essential workers, the ones that I'm talking about, and I'm not talking about the mayors, I'm not talking about the governors, I'm talking about those who were declared essential with COVID, who are the farm workers, the meat packers, the people at my campus at UNC who are the housekeepers. Those are the ones that I'm talking about. They have relatively low wages. They're going to be more exposed to COVID because they can't work remotely. You can't phone it in. You've got to go. There are going to be crowded conditions at work. Just recall that photo of the meatpacking plant. There's going to be crowded transportation because it's probably a carpool, or in some cases it's a bus. And they're more likely to have an extended family at home, so if they get infected at work, they're going to be taking that home to a larger group. So, more likely to have exposure and more likely to have a severe case because people of low income are more likely to have underlying conditions such as diabetes, as obesity, as heart conditions. And they're less likely to have health insurance. Now, I know that our state is doing everything it can for people who are infected, and I don't know what corners would be cut. But I do believe that having health insurance, that my chances of doing well are going to be better than somebody's who does not have health insurance. There are ethics of equity in this pandemic, and we've already begun to dip into those with the essential workers. But now we're looking at race and ethnicity, and in this report from the New York Times, it's looking at coronavirus cases per 10,000 people. You can see that the highest rate of infection is among Latinos or Latinx people. Next down, also very high, blacks. That next one is just an average of everybody, and then the whites are the lowest number. We can break this down a little bit further. So here we have it broken down by age. And what I would point to here is the furthest right set the furthest right stack, if you will, is in the Middle Ages, it's broader, it's wider. So what we are seeing there is workers. These are people of working age who are working on farms, working in construction, working in perhaps nursing homes where they can get infected. There is an ethics of scarcity. This is a respirator that you're seeing here, this machine. And early on, that was the biggest concern, that there wouldn't be enough respirators. We anticipated that people who get COVID also get pneumonia, have a hard time breathing, and need to be breathed for, which is what a respirator does. It pushes air in and takes it out. It breathes for you. That has not proven to be the rate-limiting factor here in North Carolina. I believe it was much more of a need in New York City, where they were attaching multiple people to a single respirator in ways they had never done before in attempts to keep people alive. But another thing is the vaccine, whenever that happens, and we've got several of them, many of them, that are in the works. And this is where we circle back around to that question of trust. We know already, just with other vaccines that we've got, that there are people who won't take them for reasons of their beliefs, won't take them because of conspiracy theories, and there are already conspiracy theories that are developing around the COVID vaccine projects. So, however, when it first comes out, those that want it, me being one of them, will be scrambling for it. And how will we decide who is going to get it first? So here we get back to this idea of who is essential. And in most lists of who is essential, the medical personnel are typically at the top, because if we lose them, then who's going to give you the vaccine? So we've got to have people who are able to take care of us medically. And then the list goes down from there to police to keep order in society, governors and mayors, as I have listed before. But my hope is that those who we have newly designated as essential will be rising in importance. For example, the housekeepers at UNC, my hope is that they will get vaccinated before I will. I would like to see that happen. So what happened at UNC? Those of you, I'm assuming that many of you are connected to UNC and maybe have been watching what has been unfolding there. Maybe some of you are not, but in short, what happened is that UNC embarked on an ambitious program to bring students back to campus and try to do so in a way that was careful, that would take advantage of all that we had learned over the months before, because we had learned quite a bit about how to deal with this pandemic. We had learned, for example, that being outside is better than being inside, that having a good airflow inside is a big help, that spacing people out can much reduce transmission, that wearing a mask is, if I were to declare a most valuable player in this pandemic, it would be the mask. So we have learned a lot, and the Chapel Hill, UNC thought, okay, let's give this a go. We can do this. We can bring people back. There was much concern amongst those who were already in Chapel Hill, awaiting this tsunami of students. We were expecting something on the order of 30,000 students coming into Chapel Hill. And so there was much worry. They came, and then a week later, they were sent home. It's like, nope, that did not work. The undergrads were sent home. The grad students were allowed to stay. So this is where I want to turn things around. If I could, I would turn the camera on you. We're not going to do that. You can be anonymous. But share with me a couple of questions you have, or thoughts that you have about the ethics of what happened at UNC.
And I want to remind you folks that you can indeed use the question button at the bottom, or if you want to throw something in chat, I'm looking at the screen for us. You have been solicited for questions, so please don't be shy, folks.
If you don't have any and you're uncomfortable with silence, I will press on, or I will ask Max to.
We do have one. We have an
okay.
anonymous attendee who
All
has
right.
asked where the students actually sent home. Are dorms closed? How about renters in town? And I guess you could maybe just broaden that to address the ethics of where are these students living and how does it affect the
So
area?
the word that was used is the attempt to de-densify the campus. And to remember how in that reproductive number it had the contact rate, and this is an attempt to lower the opportunity for contact by lowering the number of people. So the dormitories were closed. People that were rooming there were told to go home. There are some issues with that because one of the things that we have found in the comparison between China and America and the way we have handled isolation is that typically here in the U.S. we have sent people home where there are others who are non-infected and could become infected. And in China, other countries I'm not remembering, they have been sent to designated places where only infected people are. But in our case, in the case of UNC, students were sent home. Now, those that are living in the town and renting, they were not sent home. Well, they were home, I guess. But their courses are all going to become remote.
We have a few questions and comments, including from Bill Harrington, letting us know what he thinks. Thank you, Bill. Starting school was a dumb thing to do. Money before health and safety, and I guess we can think of those considerations, not necessarily a question. We also have just questions about whether you or the School of Public Health, how involved were you or the School of Public Health in these policy decisions?
So I was involved tangentially. I was asked. So there are a couple of key players involved in the UNC scenario. There is the Board of Governors that are over all 17 campuses of UNC. Then we go down to the chancellors. So in Chapel Hill, UNC Chapel Hill, it's Kevin Guskowitz is the chancellor, and then the provost that he works with, Bob Bluen, who is the two of them are working very closely together in managing UNC. And they then sought advice from others that guided them principally in the epidemiology and the biology of how things are, what's possible in bringing students back. There is also a faculty executive council that the chancellor answers to and that advises the chancellor. There's a give and take between them. I have on occasion spoken with the faculty executive council. I think about this time yesterday I was doing that. And on occasion I have also spoken with the chancellor. The lens that I bring is ethics. Even though I'm an epidemiologist, they have people who are covering that, and so I bring my epidemiologically informed ethics into the discussion. I see another question coming, but I want to finish this one just real quickly and say that one of my concerns with how things were handled here at UNC was an over-reliance on the biology and the epidemiology as the key factors, and where I would have liked to have seen more reliance on things like psychology and sociology and how we might expect students to interact. It was said in a setting that I'm not going to detail by somebody who I would say should know better, said we couldn't predict how the students would behave when they came to campus. And I differ with that. I think we could. I think we could. We had a lot of students that were cramped at home with their parents, and now they are freed and able to come to campus and be with their friends. And I think we could have predicted what would have happened.
So, and that does address. We had a question from Judy Lilly, our good friend, where college-age kids' behavior is considered. So, I think you've addressed that not well enough or incompletely.
They were not considered well enough. What I've tried to reflect in my presentation here is that biology is important. It's a factor, but it's not the only factor. There are other issues that we need to be thinking about. And I feel like in our thinking here at campus, that we're too focused on biology.
We have, again, sort of combining some of these questions from an anonymous attendee. Do you personally think that the ethical trade-offs justified bringing students back to Chapel Hill? The costs of not reopening were potentially greater than the cost of opening. That's as a question, were they?
Yeah, that's very true. So for those of you who have good eyesight and you look very closely at this page, you will see a word that I have blocked out. I have blocked out a couple of letters. The Daily Tar Heel called this a very graphic word that I am not going to repeat on this microphone. But their word is quite descriptive of what we have had to deal with. There are so many variables. I do not envy this chancellor or the provost. The decisions that they have had to make have been just mind-boggling. But I also want to take you back, remind you that it was not their decision. The decision was at the Board of Governors. So the Board of Governors are the ones who decided how all of the campuses were going to behave, and all of them were going to bring students back. When we reversed course at UNC, there were some very quick back and forth between the Chancellor and the Board of Governors arguing the case that, no, we need to reverse things now. We need to have one of these off-ramps, as it's called. Did I answer the question, or did I waffle?
I think you answered the question, and,
okay.
and we have follow-up questions, which kind of allow me to wade back into it.
We've hit a nerve here. Okay.
So the other question is, this is from our good friend Sarah Gear. What are the ethics of sending undergrads away from the dorms but keeping football players in dorms and gyms on campus and continuing to play a high-contact sport?
Yes. Is that a question, or is that a statement?
What are the ethics? That is a question. What are the ethics?
I'm hearing that as a statement, and I would not disagree. I would not disagree with that. I don't think it's wise to be doing that. We've got, trust is very thin right now at UNC, and keeping the football season seems to point to is the focus on economics, and that's not a good message to be sending at this time.
So, Jim, I have questions. I've got a couple questions that are a little bit more general that I might feed you after we go through a few more slides. But the ones related to college and to UNC's situation in particular, one is what do the students say about their view of the ethics of the UNC decision making regarding the original opening of school? And I would just point to the Daily Tar Heel article, perhaps.
Yes. One could look there, but there was an unfortunate article in the Daily Tar Heel that I felt was not gracious. It was perhaps we could even go so far as saying it was mean-spirited, and that's not something that I agree with. I prefer to say that we are in this world-class difficult situation. The Board of Governors and the chancellors, they do have to weigh these questions of the economics of the campus. We are now facing some serious cuts to this campus. It's going to affect the mission of what we are doing. Now, my personal belief is that the path to a recovered economy is a recovered pandemic, that we need to overcome the pandemic to get into a cleared economy, which means we need to act decisively in doing the restrictive things that need to be done, and we have done them in half measures. They have been uncomfortable, they have tried our patience, but still we have done them in half measures. We opened the gates too soon, we returned to the streets too soon, and that is making everything difficult. So I want to extend grace to those who have been in these very difficult positions. I don't want to demonize them. At the same time, I'm willing to say that there are some things that should have been done differently.
So, Jim, I'm going to summarize a couple of the remaining questions related to education in general and to UNC, and then there are other questions that are a little bit broader that we might hold towards the end.
Sure.
So the remaining questions about UNC is, one of them was about testing, and I just want to find out where that was. Why weren't all incoming returning students tested when they arrived on campus, and would that be a lesson learned going forward? But also a more general question, which is, do you think there is a safe way to open a college campus? How do you maintain safe actions by undergraduates? So first the testing and then just in general.
Well, I'm going to go backwards. I'm going to go with that last comment first, because there was an article in the news today about Duke, our neighbor down the road, and how they are doing it differently. I can't name all the ways they are doing it differently, but evidently they are not having the outbreaks that UNC is having. Now, remember that Duke is a smaller student body. So when it comes to, is it safe to bring students back to UNC, I think it would have been tryable, it would have been feasible if we had had a very select number of students coming back. If we had cherry-picked in some way that those who can't work from home because they don't have Wi-Fi, those who there was a point where international students wouldn't be able to continue their degrees if we didn't have a course in person. Courses in person can be done very carefully. I'm here without a mask. Max is halfway across the room. So it can be done with some care, but it needs to be a much smaller number. Bringing back 30,000 students was a recipe for disaster. But if we had kept it down to a couple of thousand, then we could have perhaps managed that.
And then the other part was just about whether testing would have been effective.
Testing. Well, testing, it really depends on that smaller number. Testing at a high number would be hard to maintain. It would have weeded some people out before they came to campus. But one can test negative and still be infected. A test is not synonymous. A negative test is not synonymous with not being infected. So it would have been a matter of time before the virus was introduced and spread around. It may have been a second week rather than the first week, or the third week rather than the first week. But if we have, then some universities have done testing, and they have done it repeatedly, like every 2 days. We perhaps could have done that, but with a smaller number. Can you imagine doing that with 30,000 students? It would have required a whole industry in itself. And let's remember that when it came to the end of the summer and bringing students back, there were flares in Arizona, in Texas, and in Florida. So a lot of the equipment was being sent in those directions. It would be equipment like the tests, but also the face shields, the masks, the gowns that need to be worn when a test is being administered. Those things were being redirected to the places of need. So having a reliable supply would have been a challenge for the number of students we have. So the key, again, is with a much smaller number.
And like I mentioned, we have many other questions that are a little bit more general in nature, so I would let you continue with your presentation. And
okay. We're on the home stretch, so I'm going to press on, and then we'll have more questions. But thank you that was fun. Thank you for that. I want to speak about upstream and downstream ethics. That this lovely picture here is it's going to be upstream, and the people downstream of this are going to have to deal with it. And in our case, the downstream ethics that I'm talking about is that we have a situation here, not just in Chapel Hill, but in our country, where our rates are much higher than what we see elsewhere in the world. Let's just take Europe as an example. The rates in Europe are at a lower level, and even though they are experiencing some resurgences in some places, they're not resurgences at the level of what we are experiencing at a regular level here in the U.S. So their resurgence will be easier to get a hold of and to bring back down. We in this country you could call it making decisions or making bad decisions or avoiding decisions altogether. But you saw in that slide where I showed you the communication, the lag in communication and the confusion in the communication that led to a confused, delayed response. Think back to the slide where I showed you the comparison between San Francisco and New York, and now put this on a national level. Those were the upstream decisions that have set the stage for everything that we are experiencing right now. If things had been done differently in the US, we wouldn't be having these decisions to make now. We wouldn't be caught in what we're perceiving as these ethical decisions. This is one reason why I have used the word grace in the midst of this mess, because we have inherited this backdrop of a huge number of cases that makes everything more difficult. So, upstream ethics, downstream ethics. We are living in the downstream. I want us to remember some context of other contexts of what we are living in this age, in this era. One of them is a declining trust in institutions. Just for decades, that has been going on. In my lifespan early on, I'm old enough to remember the Pentagon Papers, when these were papers that documented how the government was thinking and planning and acting in Vietnam. And in these papers, it became clear that they were knowingly lying to the American population about decisions made. That was, in my lifetime, the first big hit to an institution. Then came Watergate. Then other things have followed. So many of them, I can't list them all, but we could mention sex scandals in the church. So that institution has been questioned. More recently, very currently, we're looking at how police forces are operating in cities, and instances of and patterns of police brutality, so loss in that institution. Public health is an institution, and we're seeing some pushback even on that institution. Some of my colleagues who are working in health departments are resigning and are retiring early because the pushback to the directives that have been given to populations have been fierce and oftentimes personal. We've had a declining investment in institutions. There's been a declining investment in the Centers for Disease Control, and where there is a lot of planning that went on in preparing for pandemics. I've described to you my role in that, but the office that was preparing for emergencies, the director left, and it was left empty, as so many offices are. So, whether actively or passively, these institutions have declined in their resources. There is also in America an anti-intellectualism that it is linked in part to postmodern thinking. Postmodernity, well, let me back up. Modernity, the modern thinking, philosophers forgive me. I'm going to speak as a plain-spoken person here. But modernity is the idea that if we use science and reason, we will all agree with the solution and we will follow with that solution. That's a modern idea, that rationality will save the day. Postmodernity says that, well, you're going to call your idea rational, but you had an agenda behind the data that you selected to build that argument. And you're actually using what you call rational as a stick to beat over my head because you want to change the way I'm thinking. So postmodernity says that there is no central way of thinking that we can all agree to. There is no flag that can be raised that we will all salute. But a scientific study can be challenged as having been cherry-picked to make a particular point. So the strength of arguments is weakened. And then there is, of course, our political polarization, which will continue after the election. It will continue whether Biden or Trump is elected, and when Trump is gone, it will probably continue then. It's something that's going to be with us for a while. But what we see in this polarization is finding a bubble where we get the news that reinforces our preconceived notions of things. And so we just build up our ammunition for particular arguments and lose our ability to listen to other arguments and to modify our thinking. Yes.
If I might interject with questions that just seem pertinent to what you're talking about. So I have been looking at questions from, I want to make sure you have this right, Kenneth Zeitler, as well as a question from Sam Jackson, and they're both similar questions. Kenneth asks, to what extent is American individualism to blame for these results? And Sam Jackson asks, how about the cultural aspects of behavior where the culture is less individualistic than here and is more collectivist?
Very good thought. Very good thought. I should add that to this list. American individualism is a major factor. I know this because after I finished with that first version of the Code of Ethics, I said to my colleagues at CDC that code was specifically for America, and it didn't deal with the rest of the world. We should figure out how the rest of the world thinks about public health ethics and in a pandemic. So in that instance, it was the influenza pandemic that we were planning for. So we did manage to hold a number of meetings around the world. We had, it's laughable to think that we had a meeting for Africa, one meeting in Africa, but we pulled people from the whole continent. We had one meeting for Asia, also laughable, but that's the money we had. We had a meeting for the Middle East and another one for Latin America, and we brought people from throughout those areas into these meetings to have some discussions about their perspectives. Now, one of the things that we heard was this difference in communitarianism, or there are societies that, like much of Asia, actually much of Africa, more traditional societies that have a much stronger sense of communalism, and their identity is tied up in being part of a whole. And we Americans often take our identity as being distinct from the whole. That I want to be an individual. I want to be known for me and not for us. And that lack of a communitarian perspective has a major influence on public health, which is a much more communitarian science and way of interacting with the population.
In a similar vein, especially when we look at the political polarization, our advisory board chair, Joe Rytok, thank you, Joe, for joining us, has asked, recognizing the many conspiracy theories out there, how do you recommend we attempt to establish the truth to which you deem so important?
Oh, boy. I've been trying to study conspiracy thinking. I haven't read about it nearly as much as I would like to. What I understand is that it's prevalent, perhaps more prevalent than it has been throughout history, though conspiracies have always been with us. And that, as I heard it explained recently, that a conspiracy theory develops because a conclusion is reached, and then one works backwards to fill in with details that can lead to that conclusion. And you get some pretty wildly connected things that help build that conclusion. And I have a certain amount of sympathy towards conspiracy thinking. I also lack a certain amount of sympathy. I'll just be clear about that. But the sympathy I have is that it comes out of terrifically complex situations where there is a hunger, a pain for an answer. And some kind of certainty. We are living in this very uncertain, complex situation, and it would be of great comfort to have some certainty. How to overcome this with what we're doing in public health? Boy, that is a tough question. How, being a peacemaker inherently myself, I would want to sit down with people who have particular conspiracies. I can't imagine, though, as I picture that, I can't imagine making a dent in anything. I'd probably leave the room half believing their conspiracy. I'm gonna say I don't have an answer to that one. I'm sorry.
It certainly is a condition in American politics and polarization right now, though, for sure.
It is. Yes.
Thank you. I have other questions that might be towards the end.
All right. So now what? Where are we headed now? Antivirals are going to be here sooner than the vaccines. Antivirals are something that you can take should you get infected, and it would decrease the symptoms, shorten the duration of your infection. Remdesivir is one that is often named. And when it is first available, it too will be rare, and so you're going to be hearing about questions of who gets that. I'm not here to answer that question. It's probably that question, and this whole question of scarcity is the thing that when people talk about ethics and pandemics, that is the question they first run to, is that prioritization, and often just stay there. And my belief is that that's one of maybe 50 questions that we need to address. So I try to keep us able to talk about the other 49. Similarly, who will get the vaccine first? What will we do about those who refuse vaccinations? How are we going to deal with that? I'm just guessing that I'm going to be teaching a class in May in France. I teach a course in global health. I'm doing it online this year, and I really want to go in person next year. And even if there is a vaccine, I'm guessing that I will still need to wear a mask on the airplane, because I'm going to be in a closed space, and I don't know how many people have been vaccinated. I don't know if transmission can occur. Let me give you a quick aside here. Way back in my introduction, I mentioned that I did outbreak investigations in Los Angeles. We had an outbreak in Los Angeles of measles amongst Samoans. So the Samoan community, Samoa is an island in the South Pacific. When somebody would immigrate from Samoa to Los Angeles, they would find their people, probably their relatives, and live nearby. So they developed a cluster. For reasons we don't know, they didn't get vaccinated for measles. This was 35 years ago or so that we're talking about. It could have been any number of reasons. Immaterial at this point. But even though there was, throughout Los Angeles, greater Los Angeles, a large number of people who were vaccinated and would decrease the ability to transmit in the population, when you have a cluster of people who are not vaccinated, and if one of them is sick, well, they can have their own epidemic. The herd immunity of the larger society they are in becomes irrelevant when you've got that critical mass together. Well, we could have that. I could have that on my flight to Paris when I'm headed over there to teach that course. I don't know what kind of a cluster of people I've got on that flight, so I may be wearing a mask. And then it is an ethical obligation to learn and to look back on what happened. We've done a little bit of that tonight. And there is some soul searching going on at UNC. There is soul searching going on throughout the country about what we have done right and what we have gotten wrong. It's a moral obligation for us to do that, so that as we go forward, we are more prepared for the next big thing that comes. This dashboard that I showed you a slide of earlier, I've enlarged it a little bit, and I've circled in yellow 2 of the tabs. One of them is about preparing, and the other one is aftermath. I do this only to make the point that this particular tool follows through on this notion that we have to look at the aftermath, look at what has happened, and plan for the next time around. And there are resources on this site for that. This is my last slide. So this is where you can find me, or the things that I have mentioned, the Pandemic Ethics Dashboard. I have kept a blog on Medium, which is an online place to do blogs of this nature. And if you go to this URL, you can find my blogs on the ethics of returning to UNC. And then I have a personal website down there if you want to know more about me.
Well, thank you, Jim. Can you hear the applause?
It's thunderous.
It's thunderous. Deafening applause.
I'm humbled by the applause.
Well,
yeah.
I wanted to give you a few questions that I saved because they seemed a little bit more general. One is from our good friend Bob Kuykendall, who asked, is it inevitable that there will be second, third, fourth waves of COVID infections? That is to say, are all current and likely to be used treatment methods going to fail to effectively stop the pandemic anytime soon, with or without a good vaccine?
Mm-hmm. Well, I think it's inevitable that we will have ups and downs. Now, whether we're going to label them as waves is another question. Perhaps the first slide that I showed, you saw that there were ups and downs in the U.S. And even as there were ups and downs, the consensus was that they were all part of the first wave. So let's just put aside the sticky question of labels and just deal with this more general idea of ups and downs. What I predict is that, well, and you can see it already playing out in North Carolina. We had a significant down recently, and then at the very end of that chart, there was an uptick. So we're going to be experiencing those ups and downs as we relax, and then we over-relax, and then we get, we tighten things up again, and then we run out of patience for that, and we relax some more. It's likely to be an up and down that we go through. That same kind of up and down may be aided by a vaccine or an antiviral. It could dampen the heights of those instances where we go back up. One thing that we commonly hear is that COVID is going to be with us forever. I would not confuse that with the statement that we are going to live like we are now forever. They're very different statements. Influenza is with us forever. Measles remains with us. There's only one disease that we have gotten rid of entirely, and that's smallpox. So we will see trace amounts of COVID remaining.
And a question sort of related to just what about herd immunity? This is from an anonymous attendee. What do you think of the ethics of the argument that we should simply let herd immunity solve the problem despite the short-term death rate?
Boy, I know. So the argument is, let's rip the Band-Aid off. Let's let people die. I can think of a lot of problems with that, but one of them that I will mention there is equity. The people who are going to die, it's not going to be an equitable distribution. It's going to be the people who are already suffering the most. And I would have a hard time living with myself allowing that to happen. I can stay home. I can figure out if I had to, I don't do this right now, but if I had to, I could have my groceries delivered to my house, and I could sit it out until we reach herd immunity. So I couldn't live with myself if we did that. But I don't think we need to do that. I don't think that's the way that we need to go to get to herd immunity. I believe that if we are just more forceful with how we are controlling the pandemic, that is the way to survive until we have technology that can help us along. I could say more, but let's see if there's another question.
Well, just another question. This is from me, actually, about one of the things I think about with viral infections. We have the case of rickets, is a virus that same virus, I believe chickenpox, that comes back later. Do we have a sense of that in COVID? Sort of the lingering effects of a virus, and it ties to the herd immunity question. Is that whether you really the immunity even really exists in a disease that sort of lives dormantly in you?
We don't know. It bears some similarities to some other viruses, and we can kind of, because it's part of a family, we can guess that it's going to behave in certain ways. But this particular virus is throwing us some curves that its family members don't. We recently saw the first occurrence of a repeat infection in Hong Kong. Somebody who had been infected, recovered, should have been immune by all counts, and then they got reinfected. And I think there's been another instance since then in the U.S., I believe. So that's alarming, but not with a capital A alarming. That could happen in rare instances. Perhaps it's a rare thing. Perhaps it's an exception. But if it were a regular thing, then that would be concerning. Viruses can also change in their biology. Typically they do. Typically in pandemics they do. And the way they typically change over decades is to get less virulent. The case fatality goes down over time. We saw this with epidemics in Europe in the Middle Ages. And that would likely be the case with COVID as well. But on the short term, when you're looking at a pandemic, say within a year, it can go the other way around. It can get more virulent, and this is like what we saw with the 1918 influenza epidemic. The second wave was more serious than the first.
So a general question here. We've all been exposed to the public health field, I think, more than anybody was used to, right? We've become Dr. Fauci as a celebrity, if you will, of a certain type.
Yeah.
And we certainly see if public health is obviously will be part of the process of getting us through this, and in the end, and we can look at this as a success, with obviously sore setbacks and whatnot, but a success that we've gotten through a pandemic. It seems to me like public health has a good set of criteria to consider when making ethical decisions. So my question is, how can we apply the public health model to other issues and really consider them public health issues? Things like climate change, for example, that has all sorts of impacts on people's public health. Yes. Are there transferable sets of criteria for ethics for all sorts of areas? Is everything public health?
Wow. Well, so being in public health, I would like to say that everything is public health and our powers extend broadly. But yes, there are going to be just that notion of interdependence as being a central characteristic that counterbalances the American independence, I think, is a critical component. And that often does crop up when people are talking about climate change. But I'm going to bring that scale down a little bit. Because one of the things that we have seen within COVID, we had these predictable things that were going to happen, things that we predicted would happen, and they did. The need for physical distancing, for example, the need for allocation of scarce resources. But then there were some things that we did not predict that have challenged us to think anew and to think more broadly about the places that people have control over others. There's that power issue again, and the health of those others. And now I'm talking about business places. So businesses have had to ask themselves about whether they are going to reopen, whether they are going to keep their employees employed, how they are going to bring their employees back to the meat packing plant, how we are going to eat at some affordable level if the farm workers are getting infected and now we don't have people to pick our crops and they're all just rotting in the field. So now we are into the business world. And here I believe that there are extensions of public health because these are power questions that address health of a large population. I think we're in the realm of public health, and we're going to have to look to the Public Health Code of Ethics for some guidelines of how to extend them into those settings.
Well, Jim, we are coming to the very end of our time. In fact, we're a little bit over, but we had some technical issues, so we'll get 1 minute. But I have to let our dear friend Lloyd Kramer, director of Carolina Public Humanities, get this shout out.
All right.
Should the Public Humanities be a partner for public health? Why do we need them both?
Absolutely. So let me just say.
That's the right answer, Jim.
Should I just stop right there? But let me just say, when I got my PhD, it was at UCLA. We were all required to have a minor. And the vast majority of my colleagues in epidemiology were getting a minor in biostatistics. I broke with the pack. I got my minor in cultural anthropology. And I have never turned back on that. I have so valued that perspective on the world. It has been opened so many keys to understanding what is going on. And I believe that psychology, that sociology, that even the arts are our language today. When we are wrestling with these immensely complex issues, we lack the language to describe it. It's the arts that are giving us that language, that capture those things that we want to say about the angst that we are feeling.
Ladies and gentlemen, let's all at home please put your hands together for Jim Thomas. I know we can hear it. We feel it in our hearts. Thank you, Jim. And I have a few words to say.
Okay, I will yield the podium to you.
Thank you, Jim. Again, that was fantastic. And thank you all for tuning in. And please also thank you for letting us know how we can be improving what we're offering you with this technology. And just a huge thanks right now to my colleague who is right over there. You can't see him, but Paul Bonici has been absolutely a critical part of setting all this up, our sine qua non, as you will, for our technology, learning all this. So thank you, Paul. I'm giving you a round of applause. He's giving me the thumbs up. I want to just remind you folks to go to humanities.unc.edu and take a look at our programs, including September 12th coming up, a wonderful three-part seminar with the distinguished Gerhard Weinberg talking about 1941. Later in September, we have a 4-day extravaganza on dictators. We'll be looking at dictators from Caesar through Napoleon, Stalin, and Latin American despots. We have a wonderful program coming up on elections. We're going to be looking at elections that are a little farther back in time and hopefully not quite as angst-yielding, if you will. 1800, 1860, and 1968. We'll be looking at those 3 elections in a seminar. And, of course, all sorts of other programs, including language lunches, great books, reading groups, and special events. So go to humanities.unc.edu. And also, finally, folks, I do want to encourage you to consider helping us continue to reach people by donating to Carolina Public Humanities. We need your support so that we can be sure that this university is serving all the communities in North Carolina. One more time, I'm going to ask Jim Thomas to come up and wave goodbye to you all, and thank you for tuning in. Come on up, Jim. Say goodbye one more time.
Thank you all for playing with us and letting us try this new way of speaking with you. And as a parting comment, I'm just going to say, to this point of humanities, let's not forget where ethics lies. And this has been a talk about ethics applied to a very complex situation. So thank goodness that we have ethics to help us through something like this. Thank you.
Thank you. Thank you, everyone, for tuning in. We'll see you next time.